And does that show up as recording, Desiree?
Yes, you're good to go.
Excellent. All right. Well, where are we? We're about 3 after. I guess we can go ahead and get started. I'm Shane Rao. I'm one of the associate medical directors for scheduled care and at-home care. I'm kind of the quality guy on our side of the team, so I deal a lot with measurement and outcomes. And what I'm hoping to get across today is some information on metabolic syndrome and mental illness. Hopefully, by the time we get done with our discussion today, you'll have a sense of the impact of this condition, some ways that we can try to help prevent it in our patient population, and then some options that we can think about for treatment. I am relatively new to the virtual presenting world, so bear with me if I'm trying to sort of deal with all my screens here, make sure that I'm keeping things on track. I do have quite a bit of stuff to go through. If you've ever seen me present before, you'll know that I always throw in a few too many slides. So we may skip around a little bit. If you have questions along the way, please don't hesitate to raise a hand or speak up. And Desiree, I'm hoping you can help me watch out for that. And hopefully together we'll learn a little bit of something today. All right, so to get us started, the agenda for today is pretty simple. We want to define metabolic syndrome, sort of have a good solid understanding for what we're talking about. I want to talk to you some about why it's a big deal. Metabolic syndrome is a bad thing. Our patients are at risk for it. And just how bad and just how big a risk is something that we'll be discussing. We want to talk some about how we can prevent it in our patient population. And then lastly, how do we actually treat this if it is something that is discovered? All right, so a little bit of a pretest. So what I'd recommend is just write down your answers for these things. We'll reveal the answers at the end. These are quite possibly things that you already know, but just a little bit of a way to get our minds into the game today. So first, which of the following is the most common metabolic adverse event associated with antipsychotic medication utilization? Is it hypertension, high cholesterol, elevated blood sugar, or weight gain? Next one is, which of these antipsychotics leads to the greatest risk for metabolic syndrome out of this group of meds? So is it ziprasidone or Adjuvant, clozapine, also known as Clozaril, aripiprazole, also known as Abilify, or lorazepam, also known as Latuda? Go ahead and jot those answers down. We've got 2 more. Which of the factors listed here is not part of the set of criteria for metabolic syndrome? Is it waist circumference, blood pressure, having a diagnosis of diabetes, or an abnormal HDL? And then last one is, which of the following are not an evidence-based method or intervention that can be used to treat metabolic syndrome? So adding adjunct treatment with metformin, recommending exercise, switching from olanzapine to aripiprazole or Zyprexa to Abilify are the brand names, or is it switching from Adjuvant to aripiprazole or Abilify? So which of those is not an evidence-based intervention that can be used to treat metabolic syndrome? All right, so moving on into our information. As we go through today, we're going to be reviewing a case together. This actually was drawn up by a resident that I was training way back in 2011, but I think the case is still relevant. We've got Mr. M, who's a 27-year-old Caucasian male. He was brought to the emergency department by the police after being found wandering in traffic. On initial eval, he's kind of guarded, appears to be responding potentially to internal stimuli. He's demonstrating some poverty of speech. Thought process is pretty tangential. He has a couple of roommates there in the ER with him who report he's been acting kind of weird over this last couple of months. And over this last week, he's even refused to leave his room. But this morning, he left the house and he left the roommates a letter, which was written mostly in symbols, just gibberish, didn't make any sense. And further, they report they've been observing him muttering to himself over the last couple of weeks. So we go on to find out that this particular individual has no history of hospitalizations, no history of suicidal ideation or suicide attempt, no previous med trials, no former providers. So this is his first interaction with mental health. It's only med history of seasonal allergies for which he takes some Zyrtec. He works regularly, day shift at Amazon, lives with a couple of roommates. Occasionally will have some alcohol and marijuana. He does have a family history that is significant for a maternal uncle with paranoid schizophrenia, and also significant for coronary artery disease in his father, and a maternal aunt who was diagnosed with diabetes type 2. In the emergency room, the patient was given some Zyprexa and Adjuvant to calm him down. He was then hospitalized from there for about 5 days. And when he was discharged home, he was referred to a Ray for follow-up, and he was taking Zyprexa 20 milligrams a day at bedtime. So that's the scenario that our person is in here. So knowing that, we're having a discussion about metabolic syndrome, and just kind of thinking about the scenario that we're seeing for this patient, what might anybody think that we would be thinking about? What should we be considering or reviewing with this patient as we get started? Any thoughts or ideas? Anyone? Bueller? So we're talking about metabolic syndrome today. So we don't know this guy's weight yet, right? We don't have any lab values yet. We know that he's just starting a medication. So he's a young guy, 27 years old. Let's assume that he's, relatively fit fellow, kind of an average person, average weight. He's going to be worried about the effects of the medications because this is his first round. This is his first time on a psychiatric med. So immediately, we also know that he's got a family history of some coronary artery disease and a family history of diabetes. So we're going to want to be careful that we're not going to put him at higher risk for this with any treatments that we're offering or suggesting. Okay. So let's talk about metabolic syndrome in general. So what is it exactly? What is it that we're referring to? It's actually a name for a group of risk factors. So it's not necessarily an illness or a disease, but it's kind of a syndrome. It's a group of factors that we are going to be watching for patients. And these are all factors that raise your risk for heart disease, diabetes, stroke, or similar cardiovascular or metabolic issues. The risk factors for this condition are part of what have been formerly known as the deadly quartet. So abdominal obesity, hyperglycemia or high blood sugar, dyslipidemia or high cholesterol or altered cholesterol actually, and hypertension or high blood pressure. Per most of the definitions of metabolic syndrome, there are actually a few out there. The criteria that we'll be talking through today come from the National Cholesterol Education Program. It was called their ATP3. It was a third report in a series of reports. And they talked about 5 trackable issues or conditions that we can monitor in patients. And essentially, if a patient has at least 3 of these, then they're diagnosed with metabolic syndrome. And those 5 factors are a large waistline. So also we can call this abdominal obesity. So that is what's more common in men, right? It's fat sort of developing around the belly, around the center of the body. And that excess stomach or belly fat tends to be more of a risk for heart disease than if you have excess fat elsewhere. So that central obesity is a critical component. High triglyceride level is one of the risks. Or if a person is taking a medication to lower their triglyceride levels. So if their triglycerides are normal, but they're taking a medication in order to get to that normal level, that's still a risk factor. Low HDL, so not all cholesterol is bad. HDL is our good cholesterol. 1 or more medications to either produce an increase in the HDL or treat the HDL, or if their HDL is too low, then that is a risk factor. HDL is a lipid molecule or a lipid substance that helps to remove cholesterol from the artery. So we want more of it. High blood pressure is another one of those 5 risk factors. And then lastly, a high fasting blood sugar. Or if you can't get fasting glucose, you can use the HbA1c as a surrogate marker for this. And with those two, again, if you're taking a medication in order to have normal levels, that's still a risk factor. So when we meet our patient, we're going to want to take a look at those 5 factors, count up how many of those are positive risks for the person, and we can determine whether or not they're diagnosable with metabolic syndrome. Here's the criteria, basically in table form. This gives you the actual numbers that we're tracking or following. Again, this is coming out of that NCEP ATP3 report, which now is 20 years old, but still holds true for diagnosis of metabolic syndrome. First, for abdominal obesity, we're measuring waist circumference. Most of the time that I hear about that measurement, you're measuring at the level of the belly button. Some people actually say measure slightly below. But you're going to be getting that measurement in clinics that I've been in. The belly button has been the reference point. And anything other over 40 inches is considered a positive risk factor for men. It's greater than 35 for women. Those are based on population averages. Hyperglycemia, anything above a fasting glucose of 110. Or if you're fudging a little bit and using the HbA1c as a factor, then anything over 6% is considered positive. Hypertriglyceridemia, any triglyceride number above 150 or equal to 150. Low HDL, which is less than 40 for men, less than 50 for women. And hypertension, which is here defined as anything above 130 over 85. So above 130 for systolic, above 85 for diastolic. It's a good question from Heather. Thank you for that. So is height considered at all with the waist? It's not actually part of the criteria, so that we don't really think about it. Round is the issue. So round in that particular area of the body is the issue. So they are not using height as a condition. However, I have seen people use body mass index as something to also track, and that might trigger an intervention for metabolic syndrome. And body mass index does take weight into account. So in the clinics where I've been before that have tracked this well, we would typically say anything more than a BMI increase of 1.5, or sometimes people would say 2, would lead to sort of a push for an intervention with someone. So moving forward, something that's very important to think about when it comes to metabolic syndrome, once we have it defined, we also want to be able to track, what are the risk factors? What are the reasons that we need to really pay attention to particular individuals? And the risk factors come in 2 flavors. There are the modifiable and the non-modifiable risk factors. So non-modifiable risk factors, as it sounds, are ones that you can't change. So we can't change our age, no matter how hard we try. We cannot alter our race. We cannot change our family history, and postmenopausal state in women is a risk factor in particular, and that of course can also not really be altered, treated but not altered. Modifiable factors for us to be concerned about. Diet is something that we can change. Our level of physical activity, whether we're smoking or drinking, the medications that we're using or that we're being prescribed, and our socioeconomic status. Those are all factors that can actually be modified. The rest of this diagram gives you a little bit of a sense for all the different factors that contribute to or are contributed to by metabolic syndrome. They're in folks with diabetes, for example, we often see higher levels of inflammatory markers. Some wind up in a hypercoagulable state, so we have to be cautious of that. Endothelia or blood vessel lining disruptions or dysfunction. And the take-home message here is that metabolic syndrome and all those different factors can contribute to someone developing diabetes or cardiovascular disease. So all of these things are connected. And we want to make sure our patients know going in that if we modify these things with them, we lower their risk for that metabolic syndrome, which lowers their risk for these conditions, both of which are really high contributors to mortality, morbidity, cost in the healthcare system. They're bad actors in US healthcare. So we want to help them understand that we can try to prevent some of these things as we go. All right, our case continued. Our fellow comes back in 3 months and we see that he's gained 25 pounds. So he went from, somewhat relatively fit to not so much, gained a decent amount of abdominal girth, right? So an increase in waist circumference. And so we can see that we've automatically got a risk factor here. We've had that gain, and that abdominal waist circumference is going to be higher than the recommended cutoff. So we know that we've got an issue that we need to work on. So should we address or assess the weight gain? Of course, yes, we should. So the question really is, how do we want to approach this person? How are we going to go about educating this person on next steps? So let me just stop there for a moment and see if there are some suggestions. What would people do first in talking with this person who's come back to us 3 months later with 25 extra pounds? You can send that in through the chat. You can unmute and try to speak, whichever way you want to try that.
This is Shelley. So commonly seen, Zyprexa, wonderful medication, but the weight gain is horrendous. And so I would probably talk to this person about their activity level, as well as their nutritional status, what's their intake, see if we can look at different choices. But then, yes, number one, we should address it. I think we have to right away. And approaching the patient very gently and talking to them about medication side effects, and then education through, movement, nutrition, and then possibly, well, I'd be looking at other medications, but sometimes Zyprexa works wonderfully. So that's my 2 pieces.
Thank you, Shelley. I appreciate that. And I think you hit kind of the important points that I wanted to get to, which is, you do have to approach gently. Weight is a sensitive issue. Quite often. It is one of those things that I have seen clinicians that I've trained have kind of shied away from. They didn't want to talk about it. We even had a little bit of an uprising in our resident clinic when I was training folks that they just didn't want to do the waist measurement. They felt like that was going to be intrusive. They felt like that was going to be insulting to a lot of our folks. And it is definitely a sensitive thing to do. You're increasing your contact with a patient in a potentially vulnerable area. So that is something to be cautious about. But we are, also providing care and medication management and medical supervision often for the patients that we're working with. And so we do need to know this information. We do need to gather this information and hopefully present it back to them in a way that they understand we're looking out for their best interest. We are their prescribers or their therapists. We are their providers, and we want to do what we can to make sure they stay healthy and avoid risks going forward. Definitely thinking about a switch in the medication, as Shelley mentioned, is absolutely appropriate, and we'll talk some more about that as we go along. But helping that person see that there's an issue that they need to work with us to work on is important.
So the first thing I would worry about is the patient's level of insight, because you were dealing with a dangerous situation in a psychotic individual, and you need to kind of know at this point whether they understand they have an illness and that they need medication treatment. If they don't understand that and you immediately start talking about side effects, you're going to lose all the benefit of treatment and everything that you've done. So that's actually where I would start, trying to improve the level of insight, even if it requires additional sessions or bringing in family or other examples of things.
That's an excellent point, Dr. Blumenthal. So, sort of knowing when to address this or when to approach this is critical. So it may be that the person is not ready to talk about side effects. They're still convincing themselves to take the medication. So you're absolutely right. Meeting with them where they are is always an important point. Shared decision-making is another concept that we talk a lot about in addressing this with someone. If they come in with that 25-pound weight gain that you're freaking out about, but they're not worried about it, they're worried about something else, you may have to put that conversation on hold for a bit to address what they're considering important in the moment. So yes, Barry, thank you for that. All right, so let me move forward. Metabolic syndrome, is it actually a big deal? And the answer, of course, is yes. In 2018, there was a report that came out from Current Hypertension Reports that referred to it as a global epidemic. It is believed now that over 1 billion people worldwide are affected with metabolic syndrome. So it's a significant problem for a large portion of humanity. Studies do suggest that the prevalence of both diabetes and obesity, so major risk factors within the metabolic syndrome category, are anywhere from 1.5 to 2 times higher in persons with mental illness versus the general population. And also persons with major mental illness have increased risk for morbidity and mortality, with life expectancy that's anywhere from 15 to 20 years below the general average. If you look at prevalence for metabolic syndrome, this again is an old slide, but I think one that's very illustrative. This first bar here, the NHANES cohort, this was a general population survey, sort of a general health survey, looking at a large number of individuals and tracking weight, obesity, a number of different basic health factors. In that group, about 21% of people were diagnosable with metabolic syndrome. Similar patient sample taken out of the CATIE trial. So CATIE trial was a comparative efficacy study for a number of antipsychotics. So these were all folks with schizophrenia or schizoaffective disorder who were stable on medications or stably taking antipsychotic medications. That prevalence jumps to 42% in that group. And if you just take the clozapine folks out of that, so the sample of patients taking clozapine, which as was mentioned earlier, along with olanzapine, is a very high-risk medication for metabolic issues. Now we're way up at the 54% range for prevalence of metabolic syndrome. So it's a big issue across the world. A lot of people are dealing with metabolic syndrome and its risks, but in particular for our patients, it's even a larger issue. So in other words, a high percentage of our patients are at risk or are potentially on the way to being at risk for significantly reduced life quality and life expectancy. And it is among one of those modifiable risk factors that contributes to that elevated risk for our folks. That, of course, comes along with risks such as smoking, lower socioeconomic status, lower access to healthcare, lots of things that we could talk about in that regard, and those are great topics for other days. But today we're going to focus on modifying that metabolic risk. And the other take-home thing here today is that our patients really care about this. When it is reported, the primary reasons that somebody stops taking an antipsychotic, for example, always toward the top of the list or at the top of the list is weight gain. And that's true for other medications as well, for the antidepressants and some of the mood stabilizers. So how do we go about preventing this? We know it's an issue. It's an issue especially for the folks that we treat. First thing, of course, you talk about it. Here are some sites that you can actually go to that have some really nice materials. I use in particular the Mayo Clinic site. There's a nice patient pamphlet there that I often refer to with my patients that talks about metabolic syndrome, risk factors, treatments, etc. The risk factors that we want to make sure they know about are the ones some we've already mentioned. Age, the older we get, the riskier it is. Ethnicity, in the US at least, Hispanics, especially Hispanic women, appear to be at the greatest risk for developing metabolic syndrome. Reasons are not entirely clear, but that is a data point that seems to be stable over time. Obesity is another risk factor. If you have had gestational diabetes or a family history of diabetes, that's a significant risk factor. And then also other conditions such as non-alcoholic fatty liver disease, polycystic ovarian syndrome, sleep apnea even are risk factors independent and of themselves. We need to look for it. So we should be monitoring or screening for metabolic syndrome. This is a cadence recommendation that came out back in 2004. We actually have this in our physician guidelines, our physician handbook as a recommendation. And hopefully we are all doing our best to try to get this information from our patients at this cadence. So again, looking for those risk factors involved and tracking those consistently over time. One of the things that I want to point out about our case here is that this individual was not seen a second time for 3 months, and that's a bad thing, or at least is potentially problematic. Hopefully, we would be seeing that person once a month, especially on a medication like Zyprexa, and really tracking this. Most likely, we would have seen an increase in weight as early as 4 weeks. It does tend to happen pretty quickly, and we might have been able to stave off some of that increase in weight that occurred. Occasionally, it's just hard to get somebody back into clinic, so we can't always do anything about this, but we want to try to follow them up faster if we can. To get a little bit more information for our case today, we did get some labs back for our person. HDL was high enough, so normal range. The triglycerides, however, were too high. So there's one risk factor that we're seeing for him. Fasting glucose was normal range. Waist circumference, however, was too high. So that is a second risk factor. His blood pressure was normal range. So right now we're 2 out of 5. So not meeting metabolic syndrome criteria yet, but he does have at least one risk factor that has been added to his list of things since starting medication. And a second one that we have discovered that is elevated. We're not sure of exactly when that occurred, but we know that that's an issue to be worked on. So not diagnosed yet, but definitely we want to try to take some action for him. So going back to our previous discussion, we want to empower our patients to know their risk factors, to know that there are things that are modifiable that they can do something about as we are talking things through with them. So again, really emphasizing those modifiable factors. We want to empower our folks to get into some heart healthy living. A lifelong commitment to a healthy lifestyle can definitely prevent the conditions that cause metabolic syndrome. And these are the recommendations that are on that Mayo Clinic site that I mentioned earlier. At least 30 minutes of physical activity most days of the week will significantly reduce risk. Eating lots of veggies, fruits, lean proteins, whole grains, limiting saturated fats and salt, maintaining a healthy weight, quit smoking or don't start smoking, and try to limit the alcohol intake. Those are all simple things that we can bring out right up front to make sure that our patients know how to strive for this healthier living. The suggestion is always to talk about this at every visit and as much as is possible, because healthy living is important all the time. But if you aren't able to work that in every visit, you do want to make sure you're revisiting that with patients on a regular basis. We want to tell our patients to watch themselves, right? So they should be getting regular checkups with their doctors. Hopefully in some of the clinics where we are providing care, some of this is being done already. But telehealth creates a little bit of a challenge here, right? Because we can't do some of these things directly. Sometimes we may have to help our patients find labs to go get blood draws from. We may need to refer them into primary care to get this done. But in any event, we want to try to help them get those regular checkups so these things are being monitored. What are the big benefits for empowering our folks for partnering with our patients on this? Studies have shown time and time again that with shared decision making and with addressing these concerns with our patients, we improve adherence to medication. It also improves kind of that shared decision making process if we're addressing not only their concerns, but also concerns that are putting them at risk for future damage or future issues. There's an improvement in quality of life if patients are living healthier. And there's an increase in lifespan if patients are living healthier across time. And as I mentioned previously, telehealth does pose a challenge here, but those are overcomable issues. So we also want to be thinking about not only modifying treatment for that individual, but also thinking about our practice as a whole. I think as mental health providers, we want to try to think in a population health way when it comes to metabolic syndrome. So this is a risk that's true for our entire patient population. And we want to try to help our patients manage that risk and help the population as a whole. As we think about value-based care, as we think about sort of payers and agencies rewarding us for good care of patients, this is going to be one of those things at the top of the list to monitor. because it really impacts general health and the cost to the healthcare system for those individuals over time. So again, let's think about this not only for individuals, but also for our group. So one of the questions that we have to ask is metabolic syndrome prevalent in our patient population? What are the things that should raise a red flag for us? What are the things that we can be tracking and flag in our system that would allow us to spring into action to help patients? And are we actually effectively preventing or treating metabolic syndrome in our practices? So first, is it prevalent? Well, most likely, right? So even if it's not prevalent in the particular population we're seeing, the risk is certainly elevated in our patient group. So it really makes sense for us to track this or to monitor for this wherever we're working. What are the things that should trigger us to spring into action? The very fact that metabolic syndrome exists and is elevated in our population should mean that we're monitoring for it. If there are one or two risk factors that are positive for patients, I think that should lead to some treatment change or some intervention. And definitely if there's a diagnosis of metabolic syndrome, we should be jumping into action with that patient. And then lastly, hopefully we're going to be able to discover in our practices about whether we're actually doing this well. Do we see metabolic syndrome rates drop? Are we seeing people get better? Are we seeing weights drop? Hopefully we're able to monitor for this over time. With Array Behavioral Health and our quality team, we're definitely going to be looking into this as we go forward and hopefully offering some options to help you look into this in your individual practices and places. So prevention, we think about three different sort of stages of prevention. There's primary prevention. This really should happen right from the start of treatment. Hopefully we're giving our patients good, healthy lifestyle counseling and interventions as we go. As prescribers, we want to try to start with lower risk medications. Secondarily, secondary prevention in these cases, if we are seeing metabolic syndrome being diagnosed, or if our patient is showing an increase in the risk factor, keep doing that healthy lifestyle counseling and intervention. That's going to continue throughout. At this point, maybe consider changing to a lower risk medication, or maybe even consider a weight loss intervention. Tertiary prevention is going to be once that metabolic syndrome is not only diagnosed, but we're seeing it progress and get worse. Keep doing that same counseling and intervention, of course, but consider changing again to a lower risk med if you haven't already. And we're going to need to add in some targeted treatment for pathologic values. So if it's their cholesterol that's getting worse, you can target a treatment. If that's outside your scope of practice, you can refer for treatment with an appropriate provider. Often when you get to this point, you're going to be considering a referral to a specialist to make sure that everything's being monitored properly. Okay, so I'm going to be talking mostly about medications here for a little bit. So I do want to stop for a second and see if there are questions that have popped into people's minds along the way. So I'm either explaining really well or I bored you guys half to death. Hopefully explaining, I'm going to go with that. So the next steps that we want to talk about is, we discuss, and Dr. Andrus had also mentioned the possibility of switching medications. So I'd like everyone to just understand, prescribers or otherwise, most of the research that's been done in this, at least that I've seen, has focused on the atypical antipsychotics. They seem to be the group that causes the highest medication attributable risk for metabolic syndrome. They are not the only ones, but these are the ones that we've got some really good data on, and ones that I just want everybody to be familiar with. So from the second generation antipsychotics, these are the newer antipsychotics, as opposed to the typical antipsychotics, which are first generation, or things like Haldol, Prolixin, Thorazine. Second generations came out and were touted as being really beneficial because they didn't cause as many of the movement symptom problems like tardive dyskinesia, tremulousness, extrapyramidal symptoms, Parkinsonistic-like symptoms that were really the first generation antipsychotics were rather famous for. So the second generations came out and it was wonderful, and we didn't have many of those movement risks, but unfortunately over time we've discovered that they have much more metabolic risk. So risk for things like metabolic syndrome and the subsequent conditions of diabetes and cardiovascular disease. Back in 2011, these were being ranked in regards to whether they were the highest risk or the lowest risk for causing metabolic issues. It was known at that point that the most offensive agents are clozapine and olanzapine. Those are the highest risk, cause a lot more weight gain, blood sugar issues, and lipid issues than most of the others. Middle of the road group includes quetiapine, also known as Seroquel, risperidone or risperidol, and paliperidone, also known as Invega. And the least risky at that time were seen to be ziprasidone, also known as Geodon, and aripiprazole, also known as Abilify. And it just so happens that that risk stratification is true across issues, or across the issues of weight gain, high cholesterol issues, or diabetes. So it's the same ranking for each of those conditions. Newer medications that had come out, after this graph was created, things like Safras, Fanapt, Latuda. There are a few others that have come out even more recently. In general, they are thought to be lower risk and probably in this least offensive category. But to be honest with you, I haven't personally had enough experience to decide whether I believe that. And the research, I think, is still a little bit young. But it seems like most of them at least are being designed to be in this lower risk category. So the next question is, how would you design a medication to hopefully be in a lower risk category? And that's going to be based on its receptor profile. So mostly, again, for the prescribers out there, but for familiarity for our therapists as well. H1 or histamine receptors and serotonin or 5-HT, the 2C receptors in particular, seem to be the receptor types that are most linked to the metabolic syndrome risk. These are part of the mechanism by which the atypical antipsychotics improve psychosis, and they are less active at these D2 receptors, so you'd still get the antipsychotic effect without as much of the movement trouble. Unfortunately, these are also the receptors where most of that metabolic risk seems to come from. So newer medications are being designed so they've got a little less activity here and are having their effects in different ways. One other thing that's important to remember when you're treating patients is what's the time frame at which we see these changes occur. And the answer is basically right away. So as soon as these medications start, patients will often begin to report changes in appetite. Studies have shown some changes in lipid numbers and glucose numbers within that first month. And again, this is occurring through those H1 and 5-HT2C receptors, and those impacts are really seen pretty quickly. The downstream effects, the diagnoses of diabetes, high cholesterol, cardiovascular disease, those are not usually seen in that first 3 months. And I think really what that suggests mostly is that we've got some time to intervene. So if we track those things early on and we're seeing those changes early on, we can intervene and hopefully prevent those later diagnoses. Coming back to our case, what we discover with our patient is that he's got those 2 risk factors, but he's being prescribed a medication to treat the triglycerides. So I just wanted to sort of ask you, and you can answer silently, would that lead to a diagnosis then of metabolic syndrome? I'll just give you a second to decide what you think. And the answer to that is actually no, because it's still just 2 risk factors. The fenofibrate was prescribed specifically to treat the triglycerides, so that's still part of the same risk factor. If they were being prescribed, say, rosuvastatin, a more broad lipid medication, then that would be considered metabolic syndrome because now you're treating both of these risk factors. All right, so in coming back to dealing with our patient or talking with our patient, again, I think we've already gone through the idea that we want to help them live a healthier lifestyle. We want to talk about their medications and hopefully make some changes there. But let's say we've tried some of those things and nothing's really working yet. What do we want to do next, or what can we add in? So, a person that we're just seeing that's starting to develop this condition, we want to make sure that they're aware of it. We want to offer resources. Hopefully all that's being done in the initial counseling and intervention stage. but we can add in some more specific psychotherapy techniques. The literature would suggest that CBT and intensive behavioral therapy for obesity are the two techniques or methods of psychotherapy that seem to have the best evidence for minimizing specifically weight gain, but also helping with just healthy living styles. So we'd want to consider referring for those or adding those into the mix of our treatment. But we can also think about adjuvant medications. And I'm going to run through these very quickly because we're getting low on time. You will be able to, of course, look back at this at the recording if you have some interest in delving in further. But the adjuvant treatments or the add-on treatments that have their best evidence so far is metformin. That really has the most literature behind it. Topiramate also has good evidence behind it, but it's a little bit less benefit than the metformin in most of the studies that have been done so far. And there's a new combination that's out there. It's being marketed as a medication called Contrave. It's a bupropion naltrexone combo. And that's shown some really excellent evidence in early trials for reducing antipsychotic-induced weight gain. So these are three that can be considered. We also have some newer medications coming forward that are starting to be looked at in our patient population. Ozempic, you may have seen the commercials for it. It's being pretty highly advertised lately. It's a GLP-1 agonist approved for diabetes. In a diabetic population, there was a study showing 14 to 16 pounds of weight loss over a 68-week trial with separation from placebo as early as week 4. So a pretty effective agent in reducing weight for people with diabetes. There are no apparent studies on this for antipsychotic-induced weight gain yet, but those are likely in process, and we're kind of waiting to see what happens there. Miricorilant is another medication that's coming up in the pipeline. It's a selective glucocorticoid receptor modulator. So far, most of the research has been preclinical. It's very promising research in rats who are taking olanzapine and have olanzapine-induced weight gain. There was a significant reversal of that weight gain with this medication. So that's now in phase 2 trials in human studies. And then lastly, samidorphan, an opioid antagonist, is being looked at in combination with olanzapine. There is a patient study that's going on at this point. We're seeing some benefit. It's relatively weak benefit, but at least is some improvement for folks. So that's another one coming down the pike. Finally, also a new antipsychotic sort of mechanism that's being explored for this particular issue. These are TAR1 agonists. That's a trace amine associated receptor. They have been shown to reverse olanzapine-induced weight gain in small studies thus far. They also show some antipsychotic efficacy in and of themselves without causing the weight gain. So not only could this be added to a more risky agent as an adjuvant, but it also may be a group of medications that can be used independently for improving psychosis without causing the weight gain. And most likely also helpful for mood stability, although we don't have any studies to show that yet. Questions about the medication side of that before I wrap up? Crickets, crickets. Okay. Let me know or send me a chat or send me an email after all this if you come up with some questions at the end.
I think Rebecca, you might have had a question. I saw your hand go up.
Oh. Maybe not. False alarm.
Just, I think she
Sorry,
needs to unmute.
no,
There we
I'm
go.
sorry, I had to unmute. There's a new med called Vraylar. Do you know anything about the effects it has with, if it's connected at all with the metabolic syndrome? I just have a relative on that and who's got some weight issues. Big time.
My sense of it is that it's lower risk. So I think it fits into that Abilify, Geodon, Latuda sort of category. But I have not personally looked at the research to back that up. I know that data's out there somewhere, but I haven't taken a peek at it myself. However, I will say with that point that I've had patients gain tons of weight on Abilify, which is not
Interesting.
supposed to be a risky medication, right?
Right,
But,
right,
individuals respond in individual ways. So
right.
We want to target those less risky medications, but always, be vigilant and keep track of it because the body's going, biology does what it's going to do.
Right.
So we just have to keep an eye out.
Exactly. Well, thank you so much.
Oh, absolutely. So just pushing toward the end, because I do want to leave a little bit of time at the end for any other questions. If we're doing everything we can and we're just not making any headway, then definitely think about referring. A nutritionist, often I've mentioned to patients, hey, does your primary care doc have a nutritionist? And, they just won't have thought of that before. So we can often get them, the primary care folks, to refer to an in-house nutritionist, which often really works beautifully because that's a collaborative approach that clinic can use. Endocrinologists are often brought into the mix in these cases if the diabetes is worsening significantly, if there just doesn't seem to be something that the PCP can do, the primary care physician can do to make things better, they'll often push forward towards an endocrinologist. Weight loss clinics are out there and can be considered as referral options. And in more severe cases, sometimes our primary care colleagues will push forward towards something more severe like bariatric surgery. Often that's occurring in cases where the weight issue is already there or is being exacerbated by something other than the medication, of course. But it is something that our patients may run across. And as mental health professionals, we're sometimes going to be getting requests to evaluate someone's readiness for bariatric surgery or their capacity to decide to get bariatric surgery. So that's something for us to continue to think about. So, just to quickly wrap up the case, again, we had our 27-year-old Caucasian guy, schizoaffective disorder, started on olanzapine, began to see lots of weight gain, and was diagnosed with metabolic syndrome. As we've talked it through, you guys have had some great suggestions of, meet him where he is, right? Make sure that we're okay with keeping his psychosis under control first. Let's not lose that. Let's not lose that benefit in order to chase after the weight issue. But if we feel that he's got insight, we feel that he's doing well with us, we've got a decent rapport, then we want to approach that weight concern, approach the metabolic syndrome issue, educate him about it, make sure he understands it, talk to him about his risk factors, talk to him about ways to improve his own health, empower him to live a healthier lifestyle. And if that's not really helping us, then we can think about switching meds, adding adjuvants, or referring out. All right, so going back to those pre-test questions. First one was, which of the following is the most common metabolic adverse event associated with antipsychotic medication utilization? And our answer for that is weight gain. So not only the most commonly cited by patients, but actually the most commonly seen if you're tracking or monitoring in studies. Which of the antipsychotics is the big risk factor or the biggest risk? That's going to be our clozapine. It is famous for causing weight gain. There were scenarios where I've practiced before in North Carolina. We had some folks in the state hospital system that as soon as they started clozapine or olanzapine, they just added metformin automatically. And they actually saw a pretty decent reduction in the amount of antipsychotic induced weight gain within their system. So that is an option to consider, I think, still. Which of the factors were not a part of the criteria for metabolic syndrome? The answer for that is the diagnosis of diabetes. Hopefully, we're going to prevent diabetes. So metabolic syndrome is diagnosed before. We're hoping that we can see it early so that that diagnosis of diabetes just never happens. And then lastly, which of the following was not an evidence-based method or intervention? And that's switching from ziprasidone to aripiprazole. The evidence would suggest that both of those are equally risky. So the evidence would say that making that particular transition is not going to work. However, I have had patients where it has worked in reverse, actually Abilify to ziprasidone. I haven't seen that case where it's ziprasidone to Abilify yet, but individuals are going to respond, like I said, in individual ways. So you want to keep tracking, keep monitoring, and keep an open mind about it. But there wouldn't be evidence for that particular transition. Whew. So lots of information, hopefully helpful information. So I'm going to stop there and let me just open the floor, see if there are other questions with the 7 minutes that we have remaining. As people are working on unmuting or deciding on questions, I'll also put this up here. This is all my contact info. This is being recorded today, so you'll be able to see that recording later. If you have questions or if you want to toss some suggestions or ideas at me, please use that contact info.
I think Cher, if you have a question, I see her virtual hand up there.
Awesome.
Sent you an email, I mean, not an email, a chat question, but I'll just say it. So can you help those of us who are psychiatric social workers or other kinds of clinicians with staying up to date with medications? Because that's really not the area that, I mean, I have friends who are psychiatrists and I'll hear about it anecdotally, but it would be great if maybe Array could provide us some kind of a source sheet or something like that to get more familiar with the medications being used. My second question was, how and when do you think it's possible for us to consult with the medical people that are seeing our clients, especially because there are some times when we really need to understand the goal of the medication and, you know, work together on the goals.
So that's a fantastic question. And, you know, yes, I think that's a wonderful idea for us to think about creating a resource that could be used by prescribers and non-prescribers regarding more up-to-date information on the meds. I had a slide that I developed at one point that talked about the newer meds, but those were newer meds about 10 years ago. So I will try to make it a point to update that and sort of package that up to send out. The resource pages that I had listed in one of the previous slides do also have some links that are going to be helpful for you in talking with your patients and also looking at some of the more recent information. But I'll see if we can develop an Array-specific guideline for that.
That would be great.
In terms of, you know, how often to collaborate with your prescribing colleagues, you know, I think as often as possible, but at least I would say you want to sort of think about that cadence that we showed earlier. So where it showed sort of how often you're going to be monitoring different parts of physical health issues for metabolic syndrome. So it's basically once a month for at least the first 3 months. And then mostly that's going to space out to about yearly for some things. So, you know, I think really frequent interactions with your colleagues, especially during those first 2 to 3 months, is critical, because that's when we're going to see most of the changes occur that are produced by or caused by the medications. But in my mind, you know, the ideal is that, you know, you all are able to sort of share information, share records, share resources as often as you're meeting with patients. But especially in that early stage, I'd recommend that monthly check-in if possible.
So is there a format for us to request the meeting with the medical person who's doing the prescribing?
Are you working with At Home or schedule?
No, Array.
So the Array At Home Care Service?
I guess, is that what it's called now? I just know it's called Array.
Okay, it used to be empty, then.
Yeah, exactly.
Yes, okay. So you can send a message through the Mahler system, so through the medical record system. You can drop someone an email as long as it doesn't have protected information in it. Or you can always send a message to me and I can help you get in contact.
That's great. Thanks again.
Sure, absolutely. Maybe 2 more questions, if anyone.
Yeah, looks like Sunny, if I see your hand up, if you want to go next.
Dr. Rao, you listed in your slides about, I think, 4 criteria for diagnosing metabolic syndrome. I'm a little unclear about, does the patient have to have all 4 in order to be diagnosed, or is there 2 out of 4, or how does that work?
That's a great question. So there's 5 criteria, and they have to have 3 of those 5 to be officially diagnosed. So that was the abdominal obesity. So basically their waist circumference has to be above a certain number. For men, that's about 40 inches. For women, about 35. Triglycerides for the second, anything above 150, equal to or above 150. Fasting blood glucose was another, that's anything above or equal to 110, or an HbA1c of 6% and above if you're fudging it a little bit. There was, what am I missing there? I've lost one.
the lipid levels?
Yes, well, that's the other lipid level. Thank you. So HDL, which is the good lipid, you want to make sure that that's high enough. So a low lipid level is a risk factor. And did that catch everyone? So abdominal obesity, triglycerides, HDL, fasting blood glucose, and blood pressure is the other. So any three of those five over the recommended amount or over the cutoff point would lead to that diagnosis. But then, of course, one of the take homes today is you want to act whenever you see any of those risk factors. And we really want to educate everybody, so regardless of those factors.
One follow-up question. So through Array at home, the prescribers is the schedule that they are seeing patients every month with these medications?
Yep, we're working on that. So, there are a lot of factors, of course, are involved in the cadence for someone seeing a patient, but we do definitely recommend for the prescribers once a month, especially early on. And we're working on some training and some education for our prescribers to try to get all of us on the same page with that. So we have actually a few quality projects that are running now and are soon to get started, where we're going to be tracking that in a lot more detail, so that hopefully we're helping everyone get on that same cadence. But it is the recommendation, I think that's mentioned in our guidelines, that once a month is recommended or preferred. And if you have to go less than that, hopefully that's not happening until later in the treatment cycle.
Thank you.
Sure. Good questions. I appreciate it. Maybe one more? Or if not, we can wrap up on time. Desiree, any thoughts or questions or issues to do before we finish?
Nope, I don't see anything else in the chat and no more virtual hands up, but thank you so much for hosting this session. Thank you everyone who attended. Hopefully this was good information and something that you can take back in your day-to-day. Dr. Rao has posted his information here. If anyone has any follow-up questions, feel free to reach out to him directly or myself, and I'm happy to connect you.
Great. Well, thanks so much, everyone. This was fun. I enjoyed it. Hopefully it was helpful, and I'm sure we'll talk all again soon.